And I must repeat this again, the future of research, the future of leadership in medicine is female. And to see this, it is very, very cool. It's a big thank you very much for your support for this development in diabetes care. Thank you very much for this enthusiasm. And as I said already, there are challenges we have to address as AASD, as International Diabetes Federation, as the global community of those who are passionate to improve the quality of diabetes care. And the challenges are related to the increase in prevalence of diabetes. Let's start with a warm welcome to you again, with a lot of faces of people living with diabetes on this slide, and all the activities we as diabetologists, as diabetes educators, as people who are passionate about improving the quality of diabetes care, we have to address these faces of people living with diabetes. We have to address the need of those people, because I truly believe they have the right that they deserve a better life. And of course, every one of us knows people living with diabetes where they say, yeah, it's fine, they have all the treatment, they have a good treatment. But the problem is, or the difficulty is, the people we don't know, who don't have access to diabetes care, who don't have an availability of diabetes care, and the people who do not have access to a high quality of diabetes care are many, many, many more in the world than those who have a good access. And the International Diabetes Federation is acting on it. And one of the first steps, what IDF did 13 days ago at the World Diabetes Congress in Bangkok, we released a new guideline about the treatment of type 2 diabetes. And now you might say, oh God, a new guideline again. No, it's not a new guideline. It's a guideline first time translating the existing evidence of diabetes care into different environments. So this guideline is based on the same evidence of ADA-ASD, but is translating the evidence into an optimal level of care and into a basic level of care. So same evidence addressing different levels of accessibility and availability of diabetes care. And this could be a step forward to provide also easily accessible, and let's say it in this way, cheaper diabetes care for people in their environment. But we also released the new Diabetes Atlas. It's one of the hot-selling products of the International Diabetes Federation. And you see here we are talking about 589 million people living with diabetes. You may remember last World Diabetes Day on the 14th of November, WHO has released numbers talking about 800 million people living with diabetes in 2022, and 2024, 830 million people living with diabetes. How can this be that two big organizations talk about different numbers? Who is right? Interestingly, both are right, but WHO is mainly focusing on diabetes diagnosis, on fasting plasma glucose and A1C, and IDF is focusing on OGTT. So it already points out one of the challenges in diabetes care. We have 4 different criteria which you can use independent from each other to diagnose diabetes. Does this make sense that we have 4 criteria to diagnose diabetes? And if you go into the literature, there's now also the 1-hour glucose coming up as a very attractive target for diagnosing diabetes risk and diabetes as a disease. So this would mean we have 5 criteria. If we think as a cardiologist and they say there's blood pressure, and blood pressure, there's only one blood pressure for the cardiologist, why do we have so many different ways to diagnose diabetes? This is something that needs harmonization. But what these numbers tell us, it's a big, big problem. It's an urgent call of action to do something to reduce these numbers and to prevent the further growth of these numbers. Because we, as I said it a few minutes ago, in the next 10 years, we will have a tripling of incidence in Africa. We have a massive growth of number of people living with diabetes in Southeast Asia. So what can we do to change this? This needs, and we have to address the need of people with diabetes in low and very low income countries. And we have to address the challenges in this environment. In an environment where everything is available, there's no big need to act. But in an environment where nothing is available, there is a big need to act. And this is what the International Diabetes Federation will do. But there are new changes, there are new aspects of diabetes care. Look at this slide. It might show you the increase in prevalence of diabetes in the upcoming years, but it is not. It is a conjunction of prevalence of type 2 diabetes and air pollution. So something you might say, oh, air pollution has nothing to do with diabetes. It has. If you go out of the hotel and you stand in front of the hotel and there's a nice German car coming and maybe a nice German diesel car, if you stand 5 minutes behind the running diesel engine and you take some deep breath, you might find medium-sized particles out of the diesel engine 2 days later in the insulin-producing beta cell. This is interesting. Does it mean something for diabetes? We don't know. But if we test this in cell culture, it impairs insulin secretion by 30%. So it can become a very independent risk factor for the development of diabetes. And you might say, okay, this is not so dangerous here in Cairo, or it's not so dangerous in Berlin or New York. But if we are in Delhi or if we are in Mumbai, this is a big, big challenge for the chronic diseases, also cardiovascular disease and diabetes for the colleagues there. So new determinants of diabetes. But if you, or I'm as a president of the International Diabetes Federation, I always try to make the story about diabetes as easy as we can do it. And if you think now about, and I ask you, what is the one main determinant of diabetes development? And everyone has an idea, and you might say, oh, it's A, or it's B, or it's C, or it's something different. But if we have to decide what is the one main determinant we can influence, the one main determinant driving the development of diabetes, and this is actually very, very easy, and we only have to go out of this door again, it's the consumption of fried carbs. If you have carbs and you fry carbs, at a temperature of above 130 degrees, you build bonds between glucose and fat, and these bonds are very strong. So our body only can break them down by using energy, what the body will not do, because we have a lot of cheap glucose available. So what is the body doing? It's storing them in the liver. And this is the main determinant for the development of MAFLD, NAFLD, MESH, and NASH. And the amount of fat in the liver is probably, in a few years from now, the main determinant of the speed of development of diabetes. If you have 100 grams of fat in your liver, you become a non-responder to physical activity. Oh, and this is bad, because we have a lot of different fat compartments in our body. Subcutaneous fat we can touch with 2 fingers on our body, anywhere in the body. The visceral fat. The visceral fat secreting more than 800 known peptide hormones and being associated with all chronic diseases like depression, like impotence, like dementia, hypertension, diabetes mellitus, and insulin resistance. So the visceral fat is the driver for morbidity. The hepatic fat is the driver for mortality. And this we have to change. But if we want to think about how to get the visceral fat away, it's physical activity. If you now also have liver fat and it impairs the effect of physical activity, you are in devil's cycle driving you to develop diabetes mellitus. But there's also hope. These 2 numbers are prevention of diabetes. If we would walk at 10,000 steps from the age of 22, we would not contract any chronic disease. This is cool. It means using your muscles, using physical activity. It's actually getting better. If you have diabetes and you walk 1,000 steps more than you normally do, it doesn't matter how much you are walking per day, and you increase by 1,000 steps. It's 600 meters. It's going once from here to the lobby and coming back to the room. It lowers the postprandial blood sugar twice as much as 1,000 milligrams of metformin are doing. So this is also cool information. It shows the power of physical activity, because every muscle can incorporate glucose, insulin independent. And we are not using this power of our muscles. So the true diabetology is maybe not in our brain as diabetologists, it's not in our prescription as diabetologists, it's in the muscle of our patients if we would be able to activate these muscles. We are built to walk 36 to 39,000 steps a day. So our muscles, our tendons, our bones, we are not using it. The average physical activity is only 2,700 steps of every one of us. So we are a lazy species. And this is something we have to change for ourselves, for our patients. But you might say, let him talk, we are physicians, we are scientists, pathophysiology is important. This is healthy. It's a young woman, high normal A1C, and the green arrows mean she's eating something. She's eating carbs, a lot of carbs. But the purple line is glucose, measured by sensor 1,440 times a day. And what are we seeing? There is nothing. There's a flat curve. And this is what technology has told us, that diabetes is a different disease than we thought in the past. A flat curve is normal. This is someone who's very insulin sensitive. She needs maybe 1% of her insulin to regulate blood sugar, compared to her father. Look at the father. The father is actually having a better A1C than the daughter, but a totally different curve. There's an up and down of glucose, up and down of glucose. The difference to the daughter is the father is very insulin resistant. He needs about 80% of the insulin the pancreas can produce to regulate blood sugar. And actually the father has a better A1C than the daughter because he is eating less carbs. And what are we learning from this? The first difficulty is we cannot detect this because it's still too expensive to use a sensor for screening. But I'm very sure that in 3-4 years from now, we will have sensors for 2 weeks for less than $1. It's already today possible to produce these sensors for less than 12 cents. But the companies sell them expensive because they can. And this will change in the future. In many countries in the world, there are already 8, 9, 10 different sensors available, and it will take only a few months until the prices are dropping. We have to be prepared for this, because suddenly we can use this sensor for diagnosis, for detecting behavior, for detecting cardiovascular risk, for detecting behavioral aspects. It will help us for education. So this is something we have to prepare ourselves, but also to change our treatments. And the goal of future treatment paradigms probably are not A1C anymore. It's the fluctuation of glucose, the mean amplitude of fluctuation. So anything what we do for treatment should focus on reducing the amplitude of fluctuation, because imagine 2 people and both have an A1C of 7. One has mild fluctuation and the other one has big fluctuation around the same mean. The one with the big fluctuation dies because of a stroke. The one with the mild fluctuation may not need an intensive treatment. So this will be a driver for our treatment. But pathophysiology is important. Here you see 80 years of someone developing diabetes, visceral obesity increase, the green line, blue insulin resistance goes up, and then the pro-insulin resistance is coming to add on to it. And we have a new player in this game, and this is the fat in the liver. 10 years ago, we thought if you have fat in the liver, you cannot get it away. Today, we know if you have fat in the liver, it's the catalyst, it's a booster for diabetes development. It's probably the main reason for the high prevalence of diabetes in Southeast Asia, especially India, because there, a woman in the age of 28 with a BMI of 24 develops diabetes and has only 6 months pre-diabetes. In Europe, the patient have 7 to 10 years pre-diabetes. Why is the development so fast in India? And this is related to a very fast accumulation of fat in the liver due to the high consumption of fried carbs and being a vegetarian. Vegetarian diet is more healthy than anything else, but you have the risk of eating less amount of protein. And this is, protein is protecting the beta cell. So low protein in your food, together with a high consumption of fried carbs, pushes the destruction of the beta cell. Here hyperglycemia starts, and here we diagnose the patient. So we are coming very, very, very late. We come too late for a good preventive treatment, and we have to think how we can use this red paradigm to diagnose and treat earlier to prevent diabetes from development. And if we want to do it, we have to address the interplay between these 2 fat compartments. Because diabetes is not a disease of sugar. Diabetes is a disease of the interplay between different fat compartments. And this is a big hope. Very recently it was shown if you have fat in the liver, you also have it in the pancreas. And probably in 3 years from now we say the liver fat is not so important, the pancreatic fat is the devil. So if you have it in the liver, you also have it in the pancreas, and this destroys beta cell function. But if you remove the fat from the liver, you also remove it from the pancreas, and this might restore beta cell function. But now, how to remove the fat out of the liver or the pancreas? It's fasting. If you fast for 2 weeks without eating anything, 2 weeks, 0 kilocalorie. And I understand everyone thinks now, oh no, this is absolutely impossible. I cannot not eat for 2 weeks. There are many, many more people doing this way of fasting, some people call it water diet, than those who do not. For example, the Hindus, they do up to 5 weeks water diet twice a year. And if you look into the prevalence of diabetes in Hindu population doing the fasting, it's nearly 0. So if you for 2 weeks only do a water diet, the liver fat is gone in 93% of the cases of our patient. And this is actually even cooler information than the physical activity, because this is the fastest gain of health you can generate for yourself or your patient by influencing the interplay between visceral fat and liver fat, because the liver fat is gone. And suddenly, as I told you, 100 grams of fat in the liver makes you becoming non-responder of physical activity. You walk 10,000 steps and it works like 2,000 steps. If the liver fat is gone, the 10,000 steps works like 10,000 steps. And alone this is very cool for our patient. But we also have to understand where it's coming from. Whom of you like to drink Coca-Cola? This was a question to you. Who likes to drink a Coke? There are 3 honest people in the room. Who likes to drink a Diet Coke? There are some shy people in the room. It's better to stop this. Why? On this slide, you see 380,000 patient year, and it's analyzing if you do 1 soft drink per day over the period of 1 year, how it's influencing your diabetes risk. Look at the first part. If you drink water, it's not increasing diabetes risk. So thank you to Ines Schaltut and AISD that all of us have water on the table. If you drink a soft drink, it's 40%, similar to a classical Coke, 40%. But the Diet Coke makes 60% increase of diabetes risk per year. How? How can this be that the Coke without sugar makes more diabetes than the Coke with sugar? And the answer are artificial sweetener, because they change the microbiome. And we just had a session about cancer risk and microbiome, and this is becoming the same as important also for diabetes, because there are 13 different germs invading our gut if you consume artificial sweetener. And what are they doing? They produce fatty acids bond to glucose as their stool. And it's the same combination what you generate if you fry carbs. And this is done by the germs in our gut. It's in the gut, and we incorporate this in our body the same way like we use the fat of the tiramisu. And where is getting this stored? In the liver. So eating artificial sweetener or drinking artificial sweetener every day changes the microbiome and is one of the determinants for fatty liver disease. But there's also hope. Smart health, the development of technology will disrupt our ways how to deliver diabetes care. Gray, how drugs lower A1C. Green, how lifestyle is doing it. And blue, how digital tools lower the A1C. What are young digital tools? These are smartphone-based apps. How can an app on a smartphone lower A1C? We are in the pocket of our patients. We never have been so close to our patient than being in their pocket. Every one of us is taking 1,800 decisions a day. 450 of them are related to our lifestyle. Now imagine if in the right moment, with the right motivational strategy, we influence only 10 out of the 450 decisions, but do this over the period of 1 year, we might translate this into 10 kilogram of weight reduction. So lifestyle change supported by digital tools is the future of the International Diabetes Federation. There are good examples. Here, a licensed and reimbursed app in Germany using AI, where the patient is making photos of the food and is not getting blamed for what he is eating, but the information is used to motivate him to improve the quality of the next meal. And this works very well with a reduction of A1C to 1.2 up to 1.5 over the period of 6 months. So it's like a treatment of diabetes care. Or developments from Sweden, where there's a swarm of 1,000 patients using a sensor, and these patients are tracking their lifestyle. And every patient is compared to this swarm of patients, and this apps is making clear recommendation for the patient. Today, 6:35, you inject 22 units of long-acting insulin, and then it's tracking whether the patient is doing it or not, and uses this information to improve recommendation the next time. This is diabetology out of the pocket of the patient. Now we might say, oh no, we don't want this because we are the diabetologists. Think about Rwanda, 360,000 people living with diabetes and 1 endocrinologist in the country, and a digital infrastructure which is better than Europe. So there are opportunities for low and very low income countries using digitalization and AI based on sensor technology if they are available for less than $1. Coming to the fasting again, we know that eating less is healthy. Maybe eating nothing is even more healthy than eating less. And the power of fasting is not that it is fasting, it's if you stop eating, glucose is going down, insulin is going down. Glucagon is released to break down glycogen to keep glucose level up. But what happens after 3-4 days? The same hormone glucagon, it's actually the more sexy hormone compared to insulin. The same glucagon is able to break down protein to make glucose out of it, or to break down fat to make ketone bodies out of it. So now if you fast and you lay in bed, it's breaking down proteins, it's breaking down muscles, and this is increasing cardiovascular risk. So anyone who is fasting should be physical active, walking 10,000 steps a day, because a muscle which is used is not broken down. And then glucagon is used to break down fat and make ketone bodies out of it. And ketones, a handful of ketones have twice as much energy compared to a handful of glucose. So it's a superpower for our human body. And using these ketones, using glucagon to make the ketones, why is it so interesting? Because glucagon is in the pancreas and in the liver, and that's why these 2 organs are first freed from fat. Here you see MRI spectroscopy. The cloudy stuff in the liver is the fat. This is before the fasting, and this is after the fasting. It shows the efficacy of 2 weeks not eating anything for the risk of getting diabetes. The International Diabetes Federation has installed a working group, 120 experts in the world, on fasting, and this is a proposal for the water diet I just have proposed. But this fasting and diabetes group is led by Mohamed Hassanain and Daniela Koppold, and they assess 19 different styles of fasting for the therapy of people living with type 2 diabetes. And this is one of the leadership in diabetes care from the International Diabetes Federation. There's also a group for prevention of obesity and diabetes, and it's a great honor to indicate that Ines Schaltut is the leader of this group, together with the Arabic Association for the Study of Diabetes and Metabolism. And they have 2 weeks ago released a fully comprehensive program which is using public health strategies for the prevention of diabetes and obesity in adolescents, something which didn't exist on a global scale yet. This will be published, and this contains a comprehensive campaign to leverage the ability of the healthcare systems to deliver prevention of obesity and diabetes in adolescents, with the hostage of the International Diabetes Federation, and addressing all the different stakeholder levels which are needed to reach the people with obesity and diabetes risk in this age group, to help in the family and with colleagues and friends to enable a more healthy lifestyle, and also how to track the effect of such a campaign. It includes screening for obesity, screening for diabetes risk in the population who has a higher risk. It includes recommendation for school-based programs, including nutritional aspects, physical activity aspect, but also aspects like mental health and stress, bringing the stakeholders together to address the intervention, the same quality of intervention adjusted to the need of children or adolescents having a higher risk. This is an evidence-based public health strategy, include evidence-based recommendation for physical activity, for nutritional behavior, for family-based intervention and school-based intervention. And it includes all the technology which is present in the target clientele of adolescents, as well as the need of the community and the need of the policymakers in the field. And finally, it includes modern digital technology, how to use this as mobile technology for intervention, for the prevention of obesity and the prevention of diabetes. It also includes recommendation for surgery and pharmacotherapy in this clientele. So this is a very comprehensive program which can be implemented from public health stakeholders or other partners to prevent obesity and diabetes for adolescents. And I'm very, very thankful for the leadership of Ines Schaltut to drive this group forward, to bring this group together, and to be able, also with the controversies in some positions, come up with such a paper. But there are also other activities, and it's not misspelled. I mean type 5 diabetes. So what is type 5 diabetes? It's, in the past, we would have said malnutrition-related diabetes. There was a recent consensus conference, and IDF is taking the lead on it, to develop a guideline for diagnosing, treating, and preventing type 5 diabetes. Today, it's probably a maternal malnutrition diabetes of the offspring, because the mother, if she has during the pregnancy a malnutrition with proteins, so low protein content, it's again a risk of people who are vegetarians. Then the baby or the offspring has a higher risk of contracting diabetes because it has less beta cells. And there are studies in India over 3 generations how this is becoming more and more relevant. It's more prevalent in Africa and in Southeast Asia, but this group started working 2 weeks ago. There will be a harmonization of the standards of diagnosing gestational diabetes. There are 16 different ways of diagnosing gestational diabetes in the world. Makes no sense. IDF will work to harmonize this. There's a group working on AI and diabetes, so getting all the essence, how to use AI to translate the power of AI to improved intervention for people living with diabetes. There will be new leadership of the IDF School of Diabetes, and there will be a strong collaboration between IDF, ADA, EASD, and WHO, because coming back to the discrepancy of numbers of people living with diabetes, the differences come from the different diagnostic criteria. And if you're in Europe, it's not a problem, because whatever criteria you use, it overlaps. If you are in Southeast Asia, it does not overlap anymore. And it is needed to harmonize the criteria, to harmonize the standards of diagnosing diabetes on a global scale. And I think in Chicago at the ADA, we might announce that a working group like this has started. I'm the president of the International Diabetes Federation. I have 3 goals: to be in the brain of every healthcare politician in the world, to be in the pocket of every diabetes patient, and to be in the heart of every healthcare professional. How to reach this? The brain of the politicians we will reach with a global diabetes index. We will ask every year in every country in the world, in total 100,000 physicians and 100,000 patients, about their perception of the quality of diabetes care. Translate this in an index and feed it back to the politicians. And they imagine if the Minister of Health in Egypt compares the quality of care to a neighboring country, and maybe the neighbor is 5% better, and then he might say, oh, we have to do something to be better than our neighbor. Maybe he is ignoring it, but then we do it a year later again, and then he sees the neighbor has improved, and we are on the same level. And then maybe people are coming and ask, why have you not done already something last year? Being in the pocket of every diabetes patient, imagine if the International Diabetes Federation would be a freely accessible education program for patients on the smartphone, so that the patient who has no access to diabetes care but gets evidence-based education on his smartphone, it could be a game changer for many people living with diabetes worldwide. It will not reach everyone, because also having a smartphone is a barrier, but many more than today. And finally, the fellowship program of IDF is something for the heart of the healthcare professional. So for any one of you If you are passionate about the quality of diabetes care, you are invited to become fellow of the International Diabetes Federation, and in return you will get all the education from the IDF School of Diabetes, evidence-based education for healthcare professionals for free, on the computer, on your desk, in your health center. A number of social media channels. If you have your phone with you, use this QR code, because this is a WhatsApp channel where we are, or mainly I am distributing all the activities of the International Diabetes Federation with all the invitations to participate, to share ideas, to share comments, and you are strongly invited not only to become a listener and to talk together, you're strongly invited to walk together, to give your comments, to share your ideas, because this will make the International Diabetes Federation into a living organization driving the quality of diabetes care forward. Let's look at these faces again. These people deserve a better quality of care, deserve a better life. Let's work together with all our ideas, our passion, our commitment to finally help our patient to walk away from diabetes. Shukran. Thank you very much.
Thank you, Professor Schwarz, for your illustrative presentation. Any question from the floor? Okay.
Peter, thank you so much indeed for that lecture. I wonder what your thoughts are on advertising that junk you showed earlier on, that all of us have got an incredible appetite for. One, because it's readily available. Two, it's very fast and cheap. So what is, have you thought about the strategy for IDF to tackle?
So two statements about this. I mentioned the example of Pakistan having a law to establish a banned mile around every school, so from 800 meters, and you're not allowed to sell fried products 800 meters around the school. There are difficulties also to implement it in Pakistan, but this is a very cool strategy from a public health point of view. Second, I want to use an example of my daughter. As she was 4 or 5 years old, and as she was started watching TV, she always came to me and said, "Papi, there are information sessions on the TV about what I should eat." So imagine what this has made with a child. Yeah, she thought the advertisement for fatty, sugar-containing food was information what she should eat. And we have to stop this. Yeah, there is, I would say, we have all a human right of being healthy. What is done by the advertisement with the big companies in terms of sugar, high energy containing, unhealthy, let me be very drastic, toxic food, this absolutely has to stop. And the International Diabetes Federation will do a lot to do this, but in Pakistan, it was not the International Diabetes Federation. It was the social community, the churches, the mosques, the association of more than 300 stakeholders from the communities in Pakistan, and they have pushed the Minister of Health, and actually Minister of Health was agreed. The Minister of Finance was the bigger barrier, but finally they also convinced him, and they have implemented this as a public health strategy. And I'm so proud that these aspects are also in the strategy which comes from ASSD for the prevention of obesity in adolescents, developed here in Egypt. So we have to stop the possibility of advertisement for toxic food items.
Last question. Yes.
Air pollution, and this is something we have to discuss with our patient. We ask them to take the 1,000 step. I mean, this is very important for us in Cairo. The other thing you speak about sweeter and microbiome, which is really important because most of the people think that if I'm taking sweeter is much healthier than taking the sugar. And lastly, for the obesity of young people or adolescents in Egypt and what we should do. Thank you.
Yeah, thank you very much for this comment. I totally agree. The problem with the air pollution is if you talk with the patient cannot change this because this is environment. This is we all together as community. We have to force politics to do some changes, and it will take decades. The artificial sweetener, this is something every one of us can change immediately. But if you are in Europe in a supermarket, there are 38 artificial sweeteners available and 36 of them change the microbiome. Many of them must not be declared on food items. So the difficulty starts. Even if you have the intention to skip all of them, it might be difficult. So a regional unpacked food is the most healthy strategy what you can do. And finally, this is Inas Schaltut and AASD, who has brought together a very committed group of people from all over the world, but under the leadership of AASD, to build together this prevention program. So the honor completely goes to AASD, and as I said it in the introduction, I'm proud to be a president of an organization where an organization like AASD and Inas Schaltut as person are member of. Thank you very much.